So if I could invite all of the panelists to join me at the front of the room, we will commence with our discussion, which we will shortly open up to all of you. Michelle, please. Great. I'll sit here. Okay. So first of all, let me offer, on behalf of all of us, our profound thanks and excitement for the range of ideas, apps and platforms, and really the big picture questions that you've invited us to think about. Shelley has mentioned in her discussion that we're at a kind of decisive moment of critical need and also of opportunity. And that's what I would like us, hopefully, to focus on in a variety of ways. You all know I've shared a pool of questions, and we can augment those questions with those that Shelley has posed. But let me first direct a question to Vikram and then invite others of you who might like to comment on it to do so. So, you know, last year I had the opportunity to meet with a small group of interprofessional faculty at McLean in a seminar on behavioral health. And we took up digital mental health as one of our topics. And one of the questions that came up from the clinicians in that group, who again did not have the same opportunity to do the research or yet to fully be able to metabolize it. But the question that came up for them, and maybe is on the minds of some of you today, is what about the risk of delivering mental health care through digital technology instead of face-to-face and relational technologies, if you will? There is a large body of traditional research in mental health, and particularly in the psychotherapy research literature, that suggests that the common factors, empathy, gestures, nonverbal cues, contribute quite a bit to efficacy. So, Vikram, what would you say about that challenge from those early career faculty, who are the millennials who are also adopting it and using it in their lives? Can we still maintain elements of those common factors through the digital technology?
So that's, I don't know, yeah, so that's a really interesting question. So first of all, I would say that most of the work in the global context is actually provider training. Okay. So actually, it is actually focusing on that relational component. It's teaching people how to, in fact, have those non-specific therapeutic skills that are always the foundation of any other psychotherapy, specific techniques. But I think the question you're asking is a really interesting one, because it's an existential one. If you obviously a digital app which is completely self-guided will not have that. And yet, from what I know from the literature, and they will, I'm sure, speak more to that, they perform just as well as face-to-face therapy, and perform, especially when there's a coach, but that coach can be asynchronous. So it's not even that the person is actually having an interpersonal contact. So he might be able to speak more to that. One thing I will say is that digital technologies can also be used for face-to-face. That is to say, through telemedicine. And there are many especially for serious mental illness, where it's much harder to do task sharing to frontline workers. So very often for those groups of individuals, you can be sitting in a big city hospital in a country and actually reviewing people anywhere in the country, provided you have a decent internet line. So I think you could have face-to-face. And my sense is that, having done telemedicine myself, it's remarkable how quickly you forget that actually you're not physically in the same room as the person. It's really quite amazing. Within a few seconds, it's like you're actually talking to. Think about it when you talk to your parent on WhatsApp. It's not difficult to actually get that interpersonal feeling.
Okay. And as a follow-on question, and then others of you please jump in. Vikram, what would you say the digital mental health revolution, if you will, uniquely enables? And what's the most concise argument for deploying these resources to address the kind of challenge, the chasm, the Grand Canyon that Shelley identified for us?
So in my own way of thinking of this large chasm is that it's not just a supply-side chasm. It's not just a supply-side barrier. For far too long, I think in our field, we've often assumed we need more of us. I think that is absolutely not the right answer. It's certainly true that we do need more of us, that is to say, skilled providers in many parts of the world, because there simply aren't enough or any of us. But I don't think it's a straight answer here. for example. So I think we need to acknowledge there's a demand-side barrier as well, and that demand-side barrier often has to do with rejecting some of the biomedical paradigms that we use. We have to confront that, we have to accept it, and we have to figure out how we can make our communication much more acceptable, the interventions we offer much more acceptable. It's one example, just because a lot of our conversations have been around mood and anxiety problems, is I think, I don't know, I won't speak for the US, I've been here too short a time, but in most parts of the world, most people with depression don't think they have a mental health problem. Yeah, they really view their problem as an extension of social suffering. And to force a diagnostic label down their throats is simply not something they want. And in my view, digital technologies allows us to leapfrog it because you don't need, in fact, a diagnostic label. The same applies for autism. It's been remarkable how easy it is for parents in our work to recognize their child has a difficulty with communication, but reject that they need to have a diagnostic label like autism, not least because it means nothing to them. And it's terrifying to get a label that means nothing to you. So I think digital technologies allow you to assess people's mental health in a dimensional way. It allows you to actually plot where you are according to the distress and impairment that those dimensions mean, rather than pigeonholing you into a box that you have a disease and not have a disease, which in any case is not the way nature really crafts mental health.
Okay, terrific.
If I could jump
Please.
in. So I thought your initial question was really interesting, and I wanted to sort of answer it with two examples. One is a technology that was created at MIT, and it's primarily now being used in marketing and looking at responses to television ads. But basically, it's facial recognition, and it looks at the face of the consumer while they're watching something, and is able to identify whatever 340 different emotions that come out of your face, and then mimic that, right? So if they recognize, for example, that you're feeling sad about something, the avatar on the screen would replicate that and sort of actually replicate the empathy, right? So it's sort of reflecting back from you. And there was a study done by Northwestern on that, using avatars, and they found that people using that system versus an avatar who didn't have that facial recognition were 3 to 4 times more engaged and had better outcomes. So I think for us to say that we can't replicate the empathy, probably short-sighted. Technology is really catching up. And today they use this for to tailor advertisements, right? So they look at you watching an ad, and they see how you feel about it, and then they can tailor how this ad makes you feel second by second, right? And like if there's moments in the middle that don't make you feel good, they'll change that. So that's one example I wanted to lead with. The other thing I wanted to say is we can go beyond the current ways in which we think about interactions, patient-provider interactions. And one of my favorite examples is we did a study about 15 years ago where we came up with an avatar for discharge planning. So a study where patients actually were divided into 2 groups. One group got actual nurses to do discharge planning, and the other group got the nurse avatar on a computer screen. And we looked at outcomes, and we were measuring things like knowledge, retention of knowledge, how prepared you are for your discharge, do you have readmissions, et cetera, et cetera. And we found that in every single dimension, the group that got the nurse avatar performed significantly better. And when we dug deeper, what we found was that patients felt like they weren't being rushed. They felt like they could ask questions. They felt like they could rewind the tape and watch it again and again. But with a real nurse, they felt like they couldn't do that as much. And so they were accepting a lot of the knowledge without really pushing back. And so that's interesting, right? So I mean, that's taking the interaction that we're having from a human to human and actually augmenting that in a way that's really meaningful. So I think I would encourage us to think about not just what we might be missing with digital, but actually dimensions that might be added that's impossible to add with other human beings.
So kind of augmented relational technology. That's terrific. Dave, let me put a question to you if I could. You really brought us into the world of thinking about workforce development, as did Vikram, including with your postdoctoral announcement at the end of your presentation. So most of our current medical students, residents, and mental health professionals are digital natives, the generation that's coming into their careers and into leadership. But many of our faculty and preceptors are not yet there. So what has to change in our training models and in our teaching to prepare clinicians for a world of technology-integrated treatment? And then the second question would be, as we think about the end users of patients, families, and other clinicians, how can we best prepare people to be able to adopt these new technologies in the kind of formal training systems that we have in medical school with professional organizations where we have to be accredited by one entity or another?
Boy, that is a complicated question. I think because you're really getting at the heart of how do we define education and how is education structured in our society, and universities and higher education, or education in general, has been largely structured by when you're very young, you get a whole broad range of things, and then it gets narrower and narrower and narrower, and then when you go into graduate or professional training, you end up going into one small sliver that you go down into. And in fact, a lot of our colleagues probably recommend to their graduate students and fellows that focus on one thing and just go very, very deep. And then they go out into a world that is complex and requires collaboration across many people, many different disciplines in order to solve problems. There's very few problems that can be solved in somebody's garage at this point. So I think part of it is redefining, and that's part of what we're trying to do in this fellowship. Is the first instance here is to really co-train people in two disciplines, and our goal is to expand that across the fellowships, and then to work with other people to develop that at the graduate level, but really begin to insert training that exposes people to other areas. And that doesn't mean that people have to become experts in those areas, but they have to be able to communicate with those other people, and they have to understand that those other areas exist. So I think that's part of it. You have a lot of older people like me who doesn't necessarily the creativity is at the younger people. I'm so excited working with the they may not have the overview, and they'll come up with some ideas that sometimes, I think this is never going to work. And sometimes I'm right, and sometimes I'm just wrong, because the creativity is really in those younger generations, and they need to, we need to be supporting them. But I think we also need to empower them. And I'm going to give an analogy here with a patient and physician relationship. So we did a small study a while ago trying to optimize pharmacotherapy in primary care, which probably most of you know. The modal number of visits for depression is 1 when the antidepressant is prescribed, usually at a very low dose, and then the patients don't get better, they don't like it, they go off. And so we just monitored their adherence and provided them some engagement, and then once a month gave some information to the provider and to the patient. This is your level of depression. These are the side effects. This is and a piece of decision support. And we gave that to the patient. And when we went into the medical records, the number of dose adjustments was really impressive. But when we went into the medical records, what drove it was not the physicians. It wasn't the healthcare systems. It was the patients who contacting the physicians saying, I got this thing saying I need my dose adjusted. So it was driven, the engagement and the improvement was driven by empowering the patients. And I think, in the same way, we're not going to change the minds of people like me. We're going to change, we need to empower, I think, younger students and our younger colleagues to be able to drive that change.
Terrific. Kamal, if I could ask you a question about the sort of innovation pipeline. And it begins with an observation that I've heard from other areas of medical breakthroughs, particularly when they're then brought to the developing world and to lower and middle income countries, that some of that innovation can have unintended consequences. Medical technologies that result in abandoned equipment or incompatible or legacy softwares, systems, things like that. How are you prospectively addressing the issue of sustainability in the digital tools that you're developing? And are there a set of principles that you think we should all adapt early on to make sure that the tools that are developed actually will be used more broadly in the ways that Vikram, for instance, has outlined for us?
That's a great question. And I think in terms of unintended consequences, there's a couple things that we think about very deeply about, right? One of them is, as you said, wastefulness, right? So like, are there resources being wasted? Are there things that we're encouraging people to buy that they might not end up using? Are we increasing the cost of providing some of these things? And then the other one is sort of, are we unknowingly or knowingly worsening disparities, right? So are we now just giving it to people who anyway, would have been able to afford a therapist within a week, or leaving some people behind that are traditionally being left behind anyway? The second question first, I think what we try to do as much as possible is figure out the lowest common denominator of what we could be able to do in terms of providing the services, right? So is there an even more inexpensive way, or is there an even more technologically simpler way that we can provide something, right, in order to make sure that we're not leaving anyone behind? What's really interesting about digital is that it doesn't mimic a lot of the other aspects of disparities. So for example, we did a study with the Boston Healthcare for the Homeless, and we found out that 65% people who are homeless actually do have smartphones, and they use smartphones much more than they use feature phones because they don't have cell phone plans as consistently, but they can stand outside Starbucks, steal the internet, and still be connected to other people. And so that's really interesting to us, thinking, okay, so that's actually a way of providing care in a way that's not been possible in the past. Similarly, for certain immigrant generations, right? A lot of immigrants use Skype and WhatsApp and other technologies to communicate with their families back home. So they're very used to video technologies, and they're very used to, probably more than people who are just have families domestically. And so in some of these cases, actually disparities, there's a way to bridge disparities and make sure that everyone's included. On the other side of sort of figuring out how do you keep it simple and cheap and make sure that there's no wastefulness, we try to make sure as much as possible that the programs we build are using technologies that people already have. So if we can build something on a smartphone or a tablet that does not require additional hardware, that would be the preference, right? So even, for example, with the Spire study, after this was successful, we're now in conversations with Samsung to say, can you in some way replicate this on the phone so that, we don't need to give people additional technologies. Similarly for video, currently we have a system that uses video technology that's very expensive, and we're trying to push very hard, we're trying to push Epic very hard to say, you need to make sure FaceTime gets included, right? So there are some of those things, and so I think the principles that come to mind are, if you can use technologies that consumers already own, that would be great. And then if you can use technologies that are sort of, can be brought down to the lowest common denominator of what people already have, that would, I think, make sense.
Can I add something to that? Because I think this issue of obsolescence is huge. I mean, who knows how long apps are going to be around? I doubt the horizon for apps is going to be that long, and it's going to move to something else, to bots or whatever. So we're in a world that's changing really fast, and I think for digital mental health to really be well implemented, we have to define it in terms of the services. Because the technologies are changing so fast, you can slip something else in. So what kinds of data are you bringing into the healthcare system? Who's going to view it? How do they need to see it? What's the pattern of communication? Who's communicating? What is the goal of that communication? What are the sort of the expectations of that provider? What are the expectations of the patient? Because the technologies are changing rapidly, and they're going to be, they can be moved in and out, but the services change more slowly. And so, having a well-defined service, digital mental health service, can allow us to then harness and adapt to the changes in the technologies.
So let me pose a question to all of you, so we can bring Shelley into the conversation as well. I want to just take us to an article that came out, I think, last week in the New York Times that had an interesting take on the digital divide. Namely, the article was focused on the preference of elite Silicon Valley families to eschew technology for their children and to give them, like building blocks to play with and, regular books, not e-books. And the point was made that in the way some of our public funding is going, particularly in education, kids in lower income communities in the US, maybe globally, are being now exposed to screens. So we have the elite on the one side sort of saying we have the technology, we don't want our kids to have it too early, and then a movement for screens to be mediating education, healthcare in lower resource communities. I'd just be curious about, did you have conversations about that with colleagues over this past week? What are your thoughts about that as we think about this issue of equity in this different way?
So I think for me the big issue of equity is that there's two things really. The first is about how old you are. I think the exposure to the digital world is different according to your age, much like every environmental factor is going to be different in terms of the impact on the developing brain. When you're 14 or 15, there is a much different neurodevelopmental context to when you're 34. And I think we need to be nuancing very much more the exposure to young people as opposed to adults. And I think we should be listening to the elites in Silicon Valley because they know something they aren't telling us. Okay. And I personally, I am actually a little concerned. I have been to some interesting meetings where there is an increasing evidence base that the more you, at that age, at a younger age, spend on a screen, the worse is your attention span. And it seems intuitive why that might be the case. Your ability to read a book is actually impaired if you spend all your time on a smartphone. But not when you're 34, because you already have a fully developed, hopefully, ability to actually switch between these different modes of engagement. I think the bigger issue of digital divide is, in my context, is women, for example, who in most parts of the world don't have their own phone. They have to use their husband's phone. So the idea of self-care and sending information to them, there's no privacy at all. The other important is rural and poorer people who have also no access to the digital world. So that's the inequity that happens in the global context, is women, poorer people, and rural folks, and also older people who also may not be digitally skilled.
Shelley, given your work with women's mental health, would you have a comment on this dimension of it?
Well, I would just broaden it out. I was just paying attention to what Vikram just said, because I think that's the issues around gender, both in terms of who has access to the technology, what types of technology, how the information is used, the likability of the technology itself, and then its effectiveness. There already is data that shows that actually differs by gender and by sex. It's not plentiful because all those studies haven't been done, and a lot of times technology is deployed and researched, but people aren't looking at the gender differences. So, but insofar as they've been assessed, they've been seen. There's been some studies that have been done in substance use disorders and adding technology to treatment. But I just wanted to say one other thing about the New York Times article. I think it's very hard for us to admit when we just really don't know something and to hold the uncertainty as we move forward. I mean, I don't think there's any doubt that we're going to move forward with digital technologies in the space. We already are. We're going to. It's a must. But I do think it's hard for us to hold simultaneously that we really don't know. We don't know the impact of technology on the early development of the brain. We really don't know that. And we don't know what it will be like to have been a child born, exposed, and raised, and what the dose might be that could be disruptive or helpful, how much, what kind. So gaining access to that kind of information, which to the New York Times' point, some people actually seem to have some of that information. It would be nice for us to be able to have access to all of that information so that we can guide our interventions, more effectively for both expanding what we can do and also to mitigate against risk that could actually be there, for the younger generations.
So we're in our last moment of the panel, and Kamal, maybe you can say a few words about this next question, which is for all of you, really. Are we in a place where we want to give our likes, if you will, to technology? Are we bullish on it, despite some of the concerns and the uncertainties?
So I'll weave in my answer for the earlier question as well. And it's really interesting to me that, yes, there may be some emerging evidence around, what the impact of technology will be on brain development, et cetera. But what we have to realize is that we're comparing apples and oranges, right? So, for people who are the elite and who have the choice of technology, no technology, access to private schools, access to classrooms where, it's one teacher with 10 kids, compared to like what technology is now enabling us to do is providing education to people who didn't have education. And so, to me, giving them the education and giving them the resources versus saying, oh, it's going to impact your brain development, so I'm not going to give you anything, like that just doesn't make sense. So I think the conceptual framework is really important in what we're thinking about. And I think that there's going to be an increase in access because of digital health in all populations, and we need to consider that. And then going forward, sure, I think once we learn a little bit more about brain development, I think we can incorporate that. But then in general, I think I'm very bullish, partly because my job depends on it, but also I think, having experienced that in other industries and having seen how they have transformed, everything from banking to car rides to airplanes to everything, I think there will be some challenges, and I think there will be something that we're going to have to be careful about. But overall, I think we can usher in an era where patients will be more in control, where they can really figure out their destiny with healthcare, where we can make healthcare less prescriptive and more balanced, and I think where we can provide access to people who traditionally didn't have access.
I think there's no better way for us to end than on that terribly affirmative point. So please join me in thanking the panelists for a very stimulating conversation.
Okay, we're going to take a quick, short break. And we'll just join us back here at 11 o'clock for our first keynote presentation.